Okay, the meeting has started, so the recording has started. I will admit everybody who is in the waiting room. Please remember, while we are admitting people, it does take a few minutes for everybody to be admitted. So we will go over that over the next couple of minutes. In the meantime, just to start things on off, my name, for those who are now in the room, my name is Dominic Zerlo, and I am the director for the Center for Medical Cannabis and Psilocybin here at New Mexico Department of Health. And this is the meeting for the Dosage Administration and Clinical Practice Committee with Ian Dunn as the chair. Just as a couple of reminders, we are recording this meeting to be posted to the website at a later time. And just as a friendly reminder when speaking, please remember to watch your language and make sure that it is appropriate so that we do not have to go back in and edit or bleep anything that is inappropriate on the meeting. So if we're talking about, for example, different particular cultivars of mushroom, just please make sure that if there is an inappropriate word in the name, refer to it by initials, and that would be fine. It is also the reason why we do not have everybody on video, because we want to ensure that we don't have to exclude a video from public view simply due to something in the background being inappropriate. Well, thankfully, that has not happened with any of the meetings regarding medical psilocybin. It has happened in other occasions, and we just are trying to ensure that we can avoid that. In addition, the other reason we do not have everybody, except for some of the board members and staff members on visual, is because we recognize that in some areas of the state, internet is not necessarily as good as it is in other areas. And we want to ensure that people are not dropped from the call more often due to issues with the bandwidth if everybody is on by video. So we do limit that somewhat. And so with that, it looks like everybody who is in the waiting room has been admitted. So I will turn it on over to you, Ian, for you to start the meeting officially and move forward.
Good morning, everyone. Or not morning anymore. Good afternoon, everyone. I appreciate you guys taking the time to be here. My name is Ian Dunn. I am the chair of the Dosage Administration and Clinical Practice Committee, and I'm here to, um, help guide this along. Can we get to the next slide? So thank you again for attending this meeting. So what this meeting is serving to do is looking at the community input from last meeting on dosage levels. While we already adopted the dosage definitions, those dosage levels are important as well. So we're going to be further discussing and looking into what we can do for that. Next slide. So again, just as a reminder to everyone, committees operate in an advisory capacity. They provide forum for individuals who may be experts but may not serve on the board due to real or perceived conflicts of interest. Committees support the board by expanding community input, incorporating subject matter expertise, and increasing participation in program development. All right, and then Jorge, if you wouldn't mind pulling up those community input dosage categories. Perfect. And I've also provided it in the chat so everyone has access to the document. But basically what I'm going over is just the compilation of what we received from the community embalmed into words. So we start with the mini dose. This is equivalent to 1.4 to 5.6 milligrams of psilocybin, but expressed in the MTP that we adopted earlier. This range is known for mood enhancement, subtle affective brightening, and no perceptual distortion. This would be usually for if we were introducing someone to psilocybin who may have had anxiety about experiences, or as an up ramp to the therapeutic doses, but that's its service point. Most psilocybin's research that I've read has had an active placebo dose at 5 milligrams. So this is within that range. So I will now allow any discussion or comments on the mini dose category, whether it needs to be changed, updated, or just general thoughts.
And for anybody not sure on how to raise your hand to speak, I have put those instructions in the chat.
James, I see your hand is up. I'm getting your microphone unmuted here. Okay, James, you are unmuted.
Afternoon, everyone, and Ian, thank you again for being the chair here. Just a couple quick comments. I like where we're sitting with this again, and I'm assuming that this is just a one-time dose, right? So, and the comments, but that's kind of where I sit with this when I look at it right now, and I do like the conversion, and that speaks to me as far as what I've used and what we're used to using in Oregon and stuff. It's right there. I think we start with that. So that's my thought. Thank you.
Alrighty, so with no other comments, we will go ahead and go to talk about the threshold psychedelic dose. This is on the end where maybe the provider or patient is having a little bit of anxiety, but not necessarily so that they want to start at the lowest dose. This would produce mild euphoria, early sensory amplification, subtle visual enhancement. It's a very light psychedelic dose, but it represents a transition point from non-psychedelic, not visually impacting, to much more perceptible psychedelic effects. Its dosage range is between 4 to 6.9 MTP, roughly equal to 5.6 to 9.6 milligrams of psilocybin. And I will now open to any comments, questions, concerns on the threshold dose. Alrighty, with no comments, we can go ahead and move on to what I would consider the most mainstream of the approaches. It is between 7 to 21.9 milligrams of MTP. It is a moderate psychedelic dose. It's on the low end of this range. Colors become more vivid, with some closed and open eye visuals. On the high end, patients may experience kaleidoscopic visuals and mild visual disturbances. This is a moderate to full psychedelic experience. It overlaps with the most commonly studied therapeutic dosage ranges, consistent with fixed dose clinical trials, demonstrating reliable psilocin exposure and therapeutic outcomes. I will open any comment, questions, concerns on the moderate psychedelic dose. All right, seeing none, we can go ahead and move on to that high intensity psychedelic dose.
Chris has his hand up.
Oh, Chris.
And Chris, you are.
Yeah, I just have maybe one, I don't know, wording thing. Should we include the word psychedelic in each of these doses, or should it just be mini dose, threshold dose, moderate dose, and high intent, and then going on to the next one, a high dose. I think intensity is relative based on people's sensitivity, and also whether they're on SSRIs, the intensity might be mitigated by some of those effects. But going back on these other ones, just that wording change, perhaps.
Yeah, that actually sounds great. So I went ahead and striked all of the repetitive psychedelic from each of the dosage, and I appreciate your comment. I also see James has his hand up.
Ian, just one comment was I just don't see administration length time. I didn't know if we needed to add that somewhere into here, or what's your thought on, when you're doing these doses, let's say I like the moderate range, but are we going to do like for us, a duration of action or a length of, we do see that in some of the other states. They're saying, hey, if you do this dose, it's going to last 4 to 6 hours. Or if you do the mini dose, it lasts this long. What's your thought on that?
I actually agree that we need different safety protocols for them. So the reason that they're broken up like this and not specifically addressed here would be so that we could defer per the specific dosage ranges, what those safety issues were to the Patient Safety and Qualification Committee. And then we would work up there to adjust things like how long they have to be in administration, how long until, they are safe to operate a motor vehicle and questions like that. But in terms of the specific doses, that could be included here. We could definitely add it. But in my head, I had deferred it to that committee.
Gregory Evans, your mic has been unmuted.
I'm curious why you're hitting 22 milligrams as the ceiling of the moderate dose as opposed to like 18, which would be kind of your classic dose category. It's not a challenge, just a curiosity.
Oh, so I always prefer to provide a little bit of wiggle room in the event that someone has, different gut biomes and other things that are going to impact the absorption and things like that. So if, for say, a facilitator, they were prescribed within a moderate dose, then that facilitator could start them and say, okay, after X amount of time, it still hasn't hit, well, we can still provide within the dosage range. So it was meant to be more so a buffer than a full-on set.
So if I'm understanding you, it's like, say we're dealing with standard landrace potency of like 5 milligrams per gram let's talk in psilocybin equivalency for a minute, just because those numbers are commonly understood. So if you have 5 and you go to therapy and they say, hey, we're going to give you 5 grams, and you sit down and in an hour you have an opportunity to updose 2 grams. Is that what you're saying?
That would be my expectation with this. That would, of course, impact things like you would have to reset your administration clock for when they would be good. But that was my original idea, not so much plan.
Okay. How many people in the room have done a dose that high? I see you, Chris. Copy that. Yeah, I'm not challenging it. I just think that we're a little bit outside of standard scoping on that. But yeah, I yield.
So yeah, and I would be okay with setting that MTP down to 18 if that is the consensus. And then James had
I
his
just
hand
want to be clear, I'm not specifically asking for that.
up. Okay.
James, your mic has been enabled.
And Ian, just to circle back on that, under each dose category, if a safety determines that administration length of time, I would just myself like to see it added as a category with like TBD or something. Just a thought. I just think it's important when people look at this that that's in there as well, because it's more encompassing. It's just, it kind of goes with that right underneath clinical interpretations, type of style for each one. But it could be decided later again. But just thoughts.
All right, thank you. And Gregory?
Gregory,
Interesting.
your mic is enabled.
Interesting thought. Like, I think I saw Kate mention the leeway. What if these ranges overlapped, right? Because there are so many variables in dosage and administrating uh in specific context where it's like you were saying, it's like, we want the flexibility. So what if like moderate dose went to 22, but then the high dose started at 18? So like there's overlap to consider the myriad of variables that go into deciding a dose for a specific human.
I actually think that would be a great idea to to allow overlap within the ranges to accommodate the fact that every person is going to process the medicine a little bit differently. And that would help to do our best to accommodate. So I would actually support that heavily. If, again, that's what the consensus is on.
I think it's worth exploring. I'll draw a picture.
Dominic?
Yeah, good afternoon, everybody. I just wanted to mention to remember that for this particular committee and what's kind of happening in here, very little of this is actually going to be part of the regulatory side. A lot of this is going to end up being within the guidelines. And in the end, a lot of it will end up being up to the particular practitioners, facilitators, to be able to make that. So these are guidance and guidelines, not necessarily going to be like, for example, if a facilitator says, somebody is within that moderate dose range, that they're on the upper end, that they wouldn't necessarily go into that high intensity. The guidelines are really just to sort of create a little bit of a structure for the facilitators and practitioners to work off of as they make those final determinations. Just as, for example, if you go to the doctor and they're prescribing a medication, they may have guidelines on how much to prescribe, but for a particular medication, but each individual case may be a little bit different. And so just keep that in mind. When looking at it, it doesn't necessarily need to be something where we're saying this is, at a fine level of this is what exactly happens in each situation. These are, and I don't mean that as just, but these are guidelines, not hard, fast in stone or regulations or anything on that side. I hope that helps and makes a little bit more sense.
Yeah, and as another analogy, when nurses get orders from doctors, they usually come in a range. It's like, if take this first, if this doesn't work, then try this, or it'll say morphine 1 to 4 milligrams, depending on the severity of the pain. So definitely things like that can impact it. So that the facilitator needs a little bit of leeway to breathe and kind of do their job is kind of where I was going with that. But James had his hand up.
Ian, just a thought on this too, just to get clarity. With the moderate range and the high range, are we saying again that this is a one administration session, that this facilitator, because again, in Oregon, we're allowed to split that dose, right? So let's say they get the 50, we could split it and then give it to them both. Again, this is based off their safety plan and what their intention is on this stuff. And again, with us, it would be what their medical, pathway would be, and what that intention would look like, and that safety plan would look like. But is this going to be is your thought, is your interpretation more of like a splitting? Can they split it, or is it one dose? Let's say they do say, oh, I'll do the 36 and even a range. Let's say they say I want 40. Do they get it all at once, and then do they have to come back for the second? Let's say that that second time. Are we allowed to split it? Are we not allowed to split it? What's your thoughts on this stuff with the dosing and the dosing ranges?
In my head, we would be allowed to split it. If eat the tests in order to determine someone's gut microbiome are too expensive to require from all patients. So unfortunately, what we're going to be left with is a little bit of ambiguity, and I think that being able to split a dose would be beneficial. Then you could prevent, hopefully, some of the adverse instances like bad trips or whatever the more formal way of saying that is, from happening. Then we should definitely take those actions. That's why I've given a little bit of a buffer, is to say, hey, don't go and give all 21.9 milligrams if you're doing a moderate dose out the gate. Save a little bit, see what happens. They're doing good. That's when we can either say, well, they don't need the rest, but if they're feeling very minimal effects, then we can up it a little bit, still within a safe range. But I do appreciate your input. Nathan?
Nathan, you've been, your mic has been enabled.
Just as a reminder, once we enable your microphone from the Department of Health side,
Okay.
you just need to unmute. Oh, there you go, Nathan.
I figured out. Sorry, I'm not familiar with Teams. So I just want to make sure I'm kind of clear. So the prescriber will define a dose range that can be used by the facilitator, and then it's up to the facilitator to decide, kind of use their judgment wherein they want to use that.
So we would be providing what dose ranges can be recommended, and then the provider would pick a range and say, this person should probably get a moderate dose. And then it would be up to that specific provider to say, okay, well, let's start with half of it or 3/4 reserve, and then dispense once we know kind of how they're doing, ensuring that they're in the right mindset and that we can minimize adverse instances.
Okay, great. Thank you.
Any other hands? And Chris?
I'm sorry, I'm not sure if we've gotten to the high dose yet. If we haven't, I apologize, but this appears to me that we're capping our dose limit at some point. Is that the case?
Yes, so I had originally had in our last meeting a dosage that just said I believe it was there was no maximum. It just said above 50. And then overwhelmingly the community input was to set that established cap range at 50 milligrams of psilocybin. So that's what is included in this document.
So that's already been determined through the committee, that cap?
That cap has not been determined through the committee. We have not had an official vote on it. But that was what the community input had largely said. So I had included, this document is just an agglomeration of what the community had said, and that's why we're discussing it today.
Yeah, I think I would recommend that we not have a cap on it, because again, with people that are taking SSRIs might need much higher doses to achieve the desired results. Also, I know from working with veterans that some of them need to take much larger doses than normal people to kind of get the results that they need. And so I would recommend that maybe there'd be an increased safety plan or some other method where people could receive higher doses, perhaps with extra screening.
Yeah, I do appreciate that. What I'm going to go ahead and do is just read out the high intensity dose because I think that has created a lot of intrigue as well. That way we can have a fuller conversation on it. So the ranges from 22 to 36 MTP, roughly equal to 36 to 50 milligrams of psilocybin. It's intense sensory distortions, marked alteration of self-referential cognition, and increased likelihood of ego dissolution. And it is the upper range dosing reported in depression, PTSD, and substance use disorder trials. So that's just the current language. So I will once again turn over to whoever would like to speak. Katie, if you can unmute.
Gregory, you are next. You may unmute yourself.
Thank you, Katie. Thank you, everyone. Chris, I'm with just gonna reiterate or kind of support that lane of thinking. I don't think I was aware of the conversation or like any input around capping at 50, and I would love to review those conversations. I'm very much would try to not regulate the top end. I mean, what you're looking at here is like 2 grams of zaps could easily exceed that dosage, and like there's reasons people may want to get into that zone. Again, it's back into like the therapist's discretion because we are in this container, right? Like, but I would just very much not advise capping it. Everyone else, all the other states seem to have done that for safety reasons or whatever, but like those models all kind of, they're different than ours, and we have this really unique container where we can experiment with very measurable container where we can measure things. So I don't know. I'm very much with Chris on that. So that's all.
Nathan, you may unmute yourself.
Oh yeah, I arrived late, so I didn't get to introduce myself. I'm a psychiatry resident at UNM, and other medications don't have caps like this. So there's some circumstances where you'll end up you'll need to prescribe more of a medication than is what's FDA approved, sometimes by quite a lot. And what Chris is pointing out is, I think, a great concern. I don't know of it being having any evidence in the literature yet, but anecdotally, yeah, folks who are taking SSRIs oftentimes require quite a bit more, not to get to a higher plane, but just to get to the same plane as somebody who would, same plane is not on those SSRIs. And so, of course, you need some kind of checks and balances, and the way it works with other medications is, I'm free to prescribe however much I want of whatever medication, but if there's a bad outcome, then that gets investigated, and people come and they look at the records and they say, well, why did you give this guy this much medication? And so it's that kind of that's what causes people to be more careful. If you have a bad outcome and you're within the kind of recommended areas, so you could just, instead of having hard limits, have recommendations, then it's a lot harder if there is an investigation for people to say that you made a bad judgment. But if I'm, let's say I'm working with somebody and I'm prescribing or recommending psilocybin, and I go to recommend that higher amount, it's going to be on me to really justify it, to really document my thinking, etc. And as I'm thinking now, I would also really want to know that they're working with a facilitator that I have a relationship with, that I know and trust. And I don't know if we have a mechanism for that, but that might make prescribers more comfortable to, to go to that higher amount. But yeah, at the end of the day, I think having just recommended limits as opposed to a hard limit would probably be best.
Thank you, Nathan. Chris, you're next.
Yeah, I just wanted to correct one thing. I'm uh, reasonably sure. So Oregon did put a limit on it, and I know that's created some issues for them. But as far as I know, Colorado has not. And although their program is pretty in its early stages, I haven't heard of many negative outcomes as a result of that.
And then Dominic has a clarifier on that.
Well, I actually have a recommendation. And what I would recommend is maybe creating an additional category that is other dosage as determined by facilitator or by practitioner. And that way, that would allow for in those special circumstances or situations where either the individual just on themselves needs a higher dose due to tolerance issues or anything else, or other medications. And then that way it would still be within the guidelines, but create a separate category and not actually fully capping it, but still providing some guidance.
James, you may unmute yourself.
I'm in support with Chris and Dominic and Gregory and the rest of the group as far as another category is needed. But I think that category 2 needs to be under review. So I think there needs to be a trigger. If you are going higher and above the standard that's set, there needs to be like a, what I call a per psychedelic utilization review, right? You need to have some type of trigger that makes that facilitator and that clinician trigger back to the DOH and say, hey, this is what we did. Here's the successes. Here's the outcomes. And hopefully those are positive, which I'm sure they will be, because as you guys know, with SSRIs, SNRIs, any of the other medications, as well as pharmacokinetics and dynamics of each individual person, as we sit here, those are all going to be different. And so we need the ranges, but we also need safety, and we need a type of utilization review as far as, like I've said before, we need a board. The DOH have come up with a group that sits and reviews these high doses and make sure that the outcomes are positive, because legally they will be held very accountable in that space if you're practicing above and what you thought was going to be available or what you thought was going to work and it doesn't. And so we need to be sure that that's covered, and so that legality is covered, and we need that loop back. But I am in positive favor of moving forward with this. But we need to have a review of it. Other category, like Dominic said, or something that says that. But you should be allowed to have this because of a blunting or other circumstantial. Thank you.
Gregory, you may unmute yourself.
Ian, just a math note on high intensity range 22 to 36 MTP. That should be 30.6, not 36.
Thank you. I have edited it now, and it was a typo.
Yeah, yeah, cool. Thanks, Jess.
There's just some notes from the chat. Kate said mixed feelings about the cap in the definitions. Yes, some people need much higher doses, and this will be allowed in any case. On the other hand, it would be helpful to state what the usual high dose range is. Chris wrote, one more potential language change is to remove intensity and dosage range, as it is very subjective and based on so many variables.
Alrighty, so if we added the other dosage category, it would be a dosage that's like not listed, or a dosage that is not listed in the other categories is used, then the department shall review. Then it should be permitted under department review, or what are y'all's thoughts on that?
Chris?
Yeah, I don't think that should be something the department has to review in every case. I can't remember the gentleman's name earlier, but I think he was on the right track that, you know, assuming if there's a negative outcome, that would then be investigated, but it would give the liberty for the clinician and the facilitator to work together to establish that dose on their own, perhaps with additional screenings or something would be what I would recommend.
Yeah, I was trying to say like not that they would review it preemptively, but like after the fact to evaluate outcomes. Maybe I didn't use the right words. But thank you. Yeah, that makes sense.
James, you may unmute yourself.
And I'm with Chris again, and that's what I was trying to say earlier, just to clarify again, was the review would be conducted by the practitioner, the facilitator, and of course the patient, and built into their safety plan, of course. And then you basically would fill out like a psychedelic utilization review. And then that would be submitted post, to the DOH or to that reportable. And that way we have the data and the outcome, but that would be not under segregation, under the practitioner and the facilitator would have the freedom with that patient to do that, but they would have to just report post. That's all I was trying to say. Thank you.
Jorge wrote in the chat, other dosage, psychedelic utilization review. If a dosage not listed in one of the other categories is used, the department shall review a high dosage usage. And Gregory, you can unmute yourself.
I would be interested in including in the per some metric on EDI. Like, does anyone in the room have more expertise on EDI than that can speak to how that could be included?
And Ian wrote in the chat, any administered dose exceeding the high intensity dose range shall require a psychedelic utilization review. Facilitators and providers shall have the freedom to use this. However, they should report to the department on outcomes.
Sorry, and that was supposed to not be freedom to use this. It was freedom to use the higher dose. However, they should report to the department on outcomes. So with that other dosage included, does anyone have anything else we should add?
Yeah, sorry, if I'm allowed to finish the ego dissolution inventory. Dominic just put it in there. I think this is really valuable for research, and really understand like the potential for education and research here is very, very important. And we can figure out where the efficacy thresholds for ego dissolution occur across multivariant human not just different health standards or medication profiles, but people are just different, and we still don't fully understand why efficacy of psychedelics is different from one person to the next. We have a lot of ideas, but this could help define some of that stuff, if we measure it.
So are you recommending to have us check the EDI for all dosages or just for the higher one?
I mean, I think all of them, honestly, but especially this outside category when we have like people requesting something that's just different. I mean, I think those are usually the edge cases that lead to the information that we're trying to get to. But if we do have a per on every dose that goes into a database of like state level research, that would be great. Give me the keys to read all that.
Alrighty,
Alright.
and everyone else's thoughts on the EDI? Okay. So I can definitely add it to the other dosage category. I would feel most comfortable with that. That way we're not becoming overly burdensome with what we are having facilitators do each time. They're already gonna have to do assessments that are relative to the respective disorder. So would you be in support of it for just the other doses?
All right. If that was directed at me, yes.
Kate added to the chat, I appreciate the balance of research and bureaucracy. And Chris gave a thumbs up.
Alrighty. Well, then I think we have come to a large part agreement. So I have posted the dosage categories in the chat. Does anyone else have any other points they would like to bring up? I will give you guys a little bit to also just review it. I don't expect you to read at the speed of light. Alrighty, and I see Gregory with his hand up.
I would just consider changing should to shall, just to be a little bit less soft, based if it's a requirement. But yeah, TBD.
All right, and should has been updated to shall. Alrighty, so I will now turn over to Nathan.
Hey, I'm reading that section about other dosage. I'm curious. It seems like why we're calling out the ego dissolution inventory in particular. Is it just because we've mentioned that as one of the things we want to look at? Is there? Yeah, it feels like that's being called out for some reason.
Since it was Gregory's idea, I will let him speak on it.
My thinking on that is back to James and Chris kind of talked about this need to uh, hit a specific therapeutic target may require a different dose for people with non-standard response. I guess if those are the right words, I feel like I could say that better. But in so doing that, finding out like that ego dissolution is that kind of primary target. And so understanding what variables that person has, whether it's SNRIs, whether it's um, any other variable that's causing them to need a higher dose to get to a target, that defines the target in as well as we can currently. There is some new science that includes some EEG stuff that is probably not accessible for standard use. But I think just a simple survey, such as is lined out in the EDI protocol, which is well established, it fairly simple and could help us understand where that moving target is, if that makes sense.
I got you. That makes a lot of sense. Thank you.
Dominic?
Yeah, thank you, Ian. And Greg, as you were talking about that, that made me really think about, the location for this. And I'm wondering if it shouldn't actually necessarily be in this aspect of the guidelines, but in the guidelines where we're talking about the different types of inventories and assessments that should be utilized, and which ones should be reported based on whether it is, whether it is for research purposes or for continuing just with regard to the patient for their medical care. And so I'm thinking that it actually, because this is really, none of the rest of this particular document is looking at what types of assessments should be done. I sort of feel like, while I agree that we would need to do the EDI, that really belongs in the assessment aspect of it. And so I kind of feel like, as Nathan kind of said, it sort of feels called out here, but I think that's just because we haven't done the assessment aspect and guidance yet, and it feels like that this should just be in that section. And so we could include it as sort of, pinning it to the board for making sure it gets included there. But I don't know that it necessarily should be in this section. But I think it should be where the language just says right now, shall report to the department on outcomes. I think that would be fine. And then the inclusion of what types for each category or all categories then would go under that assessment and report out.
Yeah, that totally, that makes perfect sense. And like, yeah, just define the category, as James said, and then, yep.
All right, so with that verbiage striked, which are you guys ready for a vote? It doesn't look like we have much more conversation. First, if anyone wants to speak, please raise your hand. Cool. All right, so we'll go ahead and move to a vote. Please display the screen with the voting hand for me. And to be clear on what we are voting on, it is this exact language. With the EDI portion striked, the other dosage added, but everything else remained the same. Oh, and that typo correction of 30.6. Yeah. Okay. Alrighty. If you are voting in affirmation in support of this document, please raise your hand at this time.
Ian, it looks like we had 10 hands up.
All right, please put your hands down. Alrighty, and then if you are against this document, please raise your hand at this time. And that is 0, no, 10, 4. The outline of our dose or our dosage guidelines are adopted. And since we already adopted the dosage definitions, we can now discuss what would you guys like to work on at our next meeting or at the end of finishing up of this one.
Chris?
Ian, this may be handled in a different committee, I'm not sure, but I feel like our preparatory sessions and our screenings and all of that are gonna be involved in this committee, and I think that might be a logical place to kind of to start.
All right, so yeah, now that the reason I didn't start with preparation was because I was waiting for the Patient Safety and Qualification Committee to finish their clinical support tiers, because that's going to determine what we need to check for in the preparation session. But we could definitely look at things like duration, environmental conditions. We can also look at risk factors, contraindications, and side effect profiles associated with the specific dosage levels. But yeah, that would be a reasonable next step if we wanted to work on preparation. Gregory?
I don't think I'm going to get a lot of traction behind me, but somewhere down the road, I would love to get deep into the conversation of chemotype framework and aligning specific known combinations of alkaloids towards unique therapy protocols. But I might be alone out here on that one.
I love the idea. My only thing is, let's regulate what we have been specifically authorized to regulate, and then we can worry about the alkaloids, because we still have to get everything prepped to just know
we do have, the primary alkaloids in measure, like through the other, we just passed that this morning. Like, so we'll get Baocystin an arugination. But yeah, I mean, I'm calling from the future. I'll come back later.
Yeah, no worries. So I think the most important things that we get through are administration protocols and preparation protocols, like Chris said. So why don't we accept any input on that at this time? And then what we can do is we'll accept public comment. And then at the next meeting, we can really dive deep. That way people have time to, collect their resources and sources and that kind of thing. How's that sounding to everyone? All right. So, and in terms of administration and preparation, does anyone have something they would like to say at this time, or do you guys want to submit the comments?
Ian in the chat, James wrote contraindications and safety plans for preparation, and Vincent wrote, Vincent wrote, I think starting at preparation would be appropriate. Thanks for this. And then Dominic added how people can submit written public comments in the chat.
Perfect. Yeah, so for the next meeting, we'll go through preparation and administration. If you guys would like to submit public comment before next month, business day is Monday at 5 p.m., that would be really great for us. But when would you guys like to meet again? Actually, see if I can find
It might be unlucky, but Friday the 13th would be is looking pretty free from our end.
I might have to try my luck. Is everyone okay with Friday the 13th at 9?
Gregory and Chris both have hands up.
Gregory.
I just would love a little elaboration on what you want to see or hear from us about like preparation. Like the constraints that I know we currently have is everything is ground and homogenized and sold as bulk or in capsules. So like when we get when a therapy like in the administration point, it's probably going to be in a capsule most likely or something like that. Are we looking to put regulation on how an administrator gives a thing to somebody and how that person ingests it, like or like what specifically would be the
More
most helpful?
so like duration. What does what does an environment for administration look like? Because I know there's been a lot of, maybe not in this committee, it might have been in another one, but of talk of some people like the idea of an outdoors one. I don't know that how I feel about that, but that has been something that is brought up. So in terms of administration, what kind of facility are they in? What supports does just a standard patient need? And then for preparation, what do we need to screen them for? What do we need to know if they are on or take daily? So questions like that, or not questions, concepts that would directly impact, how that person is in their administration session, and then how we prep them properly. So I've heard some things that, prep can be telehealth as long as you show them, the room and setting that they are going to be in. But each person has a different one, and I genuinely do like reading public comment. So I would love to hear what y'all's ideas on that are.
Yeah, so
but
not so
Chris-
much ingestion,
sorry.
but preparation for the experience, set and setting, that sort of stuff. Got it.
Yeah. And then Chris?
Yeah, I can't make it on the 13th. I'll be finishing up my facilitator training in Colorado. So if we could move it to a different day, I'd appreciate it, but I understand if we can. I would like to be involved in this committee though.
Would the 12th at 9 work for people?
Yeah, the 12th I'll be traveling as well.
Mm,
I could probably do it from my car.
And Ian, just from a calendaring standpoint, the 20th, we already have two different meetings, the board meeting and end of life care meeting. So if you're looking at sticking on Fridays, the next Friday would be March 27th.
I really have no preference for if it's on Friday or not. But we could. Do we have anything on March 16th?
I don't see anything. That should be pretty good.
Okay, then how does everyone feel about March 16th at 9?
Which is a Monday.
Yes. See some thumbs up. All right, well, that sounds great. I see no hands of questions, so I will go ahead and adjourn. We will meet March 16th at Monday, March 16th at 9 a.m. I look forward to seeing you guys. Thank you all so much for your time and collaboration and taking the time to read the documents. I really appreciate all of you. Other than that, I hope you guys have a great weekend.
Thank you, everybody. We really do appreciate your participation, and it really helps us to get this program moving forward and implemented. So on behalf of the department, thank you. We did put in the chat for everybody just the next several upcoming committee meetings with their registration links. But if you also would like to see them and get them as they continue ongoing, the website is also now in the chat specifically for that. And so you're welcome to go in and enjoy clicking on the links and joining meetings. So thank you, everybody.
Bye. Thank you.